Hereby I open this academic ceremony in which Ms. Cassidy-Seyoum will defend her academic thesis implementing safe and effective treatment for Plasmodium vivax malaria in pre-elimination endemic settings, a case study of Cambodia. I welcome you and wish you lots of luck together with your paranyms. I also welcome your supervisors, Dr. Engel, Professor Threemer, Dr. Lai, Professor Price and Professor Lawrence, obviously the members of the opposition, whom you will meet later, and of course your guests here on site and online. But before we start the defense, we ask you to present in a maximum of 15 minutes what you have done in your thesis.
Thank you. Dear Prorector, Chair, members of the Assessment Committee, supervisors, colleagues, friends and family, both in this room and online, good morning and good evening. In the following slides, I will be presenting a summary of my PhD research titled Implementing Safe and Effective Treatment for Plasmodium vivax malaria in Pre-Elimination Endemic Settings, a case study of Cambodia. I always like to start my presentations with this quotation from a malaria patient in Cambodia. They said, I thought that I might not be able to live anymore. Maybe I would die because I was so chilled. This shows the impact of the disease on an individual person who can also experience nausea, vomiting, fatigue, and headaches as part of the malaria symptoms. And globally, this is a disease that is the second most common type of malaria and affected 9.2 million people in 2023. Just a brief outline. I'm going to start with a brief background, then move on to my aims and objectives of my thesis, talk a little bit about my theoretical grounding and analytical lens, shortly describe my methods, and then move on to some key findings and recommendations based on these key findings, and end with future directions and acknowledgements. So my research focuses on the implementation or potential implementation of health interventions. There are often challenges in research being translated into policy and new tools or interventions being implemented. There are several factors that can affect the implementation of intervention, including logistics and supply challenges, technology specifications, socio-cultural attributes, and dynamics and relationships between patients and healthcare providers. So the successful implementation and uptake and rollout of Plasmodium vivax interventions, which is a specific topic of my research, is therefore not really a given. And an important element of what makes the implementation of Plasmodium vivax interventions more complex is its biology and the treatment that it requires. Plasmodium vivax, along with Plasmodium ovale, has a dormant liver stage that can cause malaria to come back if it is not treated appropriately. And this is called relapse. So to clear both the blood stage and the liver stage, the blood stage which causes the symptoms and the liver stage which causes the disease to come back, we need a treatment that is termed radical cure. And that includes a drug that can clear the blood stage, a cis-oncocytal drug, so we're thinking about chloroquine or artemisinin combination therapies. And then for the hypnosoncocytal drugs, the ones to get rid of the dormant liver stage, we're talking about the most commonly used one being primaquine. However, there are challenges with the hypnosoncocytal drugs, so the ones to get rid of the dormant liver stage. The first one is challenges with adherence to a treatment course that's often long, often 14 days. And then the second one is the drug-associated hemolytic risk for individuals with an enzyme deficiency called glucose-6-phosphate dehydrogenase, G6PD for short. And this is a deficiency that's prevalent in malaria endemic regions. Therefore, there is a need for effective, shorter course treatment or better treatment adherence mechanisms and an easy-to-use point-of-care G6PD test. These challenges and corresponding needs are important in malaria endemic Cambodia, which is seeking malaria elimination. So we have in Cambodia a high proportion of Plasmodium vivax cases, as well as a high prevalence of G6PD deficiency. and a lack of point-of-care testing for G6PD. As a result, a lot of patients for a long time were left without treatment. So to address some of these concerns, in February 2021, Cambodia rolled out these new radical cure interventions. One, a point-of-care G6PD test, which is semi-quantitative to the health center level, and two, as a means to check adherence and for the treatment to be safely administered, they implemented village malaria worker follow-up. Therefore, my PhD aims to understand what is needed to implement safe and effective treatment for Plasmodium vivax malaria in Cambodia. And to achieve this aim, I broke it down into two main objectives. The first is assessing the implementation of current Plasmodium vivax case management strategies in Cambodia, some of which I have previously mentioned, which is the G6PD test and the village malaria worker follow-up. The second is to understand the factors associated with the implementation of new Plasmodium vivax case management strategies, which would try to help close some of the remaining gaps. And this includes community G6PD testing, so by village malaria workers, new shorter treatment options, and enhanced monitoring for some of these new treatment options. So understanding the factors affecting the implementation of current and future interventions allows implementers and national malaria programs to improve current implementation and inform their decision-making and estimate how something might be implemented in the future. Thus, my findings from my thesis not only offer insights into the implementation of treatments, G6PD testing, and monitoring in Cambodia itself, but throughout the greater Mekong subregion, which is the region where Cambodia is located, as well as globally in malaria endemic countries facing similar challenges. So in order to understand and analyze these different interventions, I drew from multiple paradigms and theoretical frameworks to be able to create my own analytical lens. So the conceptual framework that I employ in this study allows for the exploration of several aspects and components of implementation at multiple levels. And the main thing is that it recognizes the importance of both material and relational infrastructure. So that is the tangible, the supplies and things that you can see, and the intangible, like the relationships between people, as well as the environment, the broader health system, the role of communities, and patients' agency. So the patients have a role not only in how the intervention will be, whether it will be successful, but also they should have a role in developing the intervention. So in the end, my theoretical framework and conceptual framework made sure to recognize that a successful intervention can be viewed differently by different stakeholders. Now moving on to the methods of my thesis was embedded in a clinical trial, but it went beyond this clinical trial to more routine settings to be able to understand the complete picture of the vivax case management situation in Cambodia. I used a mixed methods approach, though I relied more heavily on qualitative methods. So in terms of the qualitative methods, I did extensive interviews, focus group discussions, observations. We also gathered national surveillance data pertaining to the implementation of G6PD testing and village malaria worker follow-up. Now moving on to some key findings from my thesis, I would like to kind of highlight the common threads from the different chapters of my thesis. What is clear is that there is a need for community care, even with shorter and more effective treatments that are potentially riskier, which a lot of patients and stakeholders want, because of the importance and the connection that village malaria workers and community health workers have with their community and the patients in them. So the proximity in terms of relationship and physical proximity. Thus, to expand more complex interventions into community care and implement safe and effective treatment that reaches patients, there is a need for three elements: confidence building in village malaria workers, the health system and infrastructure among all stakeholders, a strengthening of relationship among health providers, village malaria workers, patients, and their families to enable crucial collaboration. And third, clear, situated, and updated policy and guidelines based on feedback from implementers. So in terms of the first element, confidence building, building and maintaining confidence in different aspects of complex interventions is required to implement an intervention. It is also a key component of the intervention's acceptability. And it is not just confidence in the implementer, so the person implementing the intervention, but across all actors in the health system, the technology and the infrastructure. We especially see this need for confidence building with the implementation of G6PD testing in the community. For village malaria workers and patients and health center workers and health providers, they were able to build this confidence because of VMW's prior experience with blood testing, if they had the appropriate training, with refresher trainings, so they were able to build this confidence. For policymakers, they had more trouble, and we needed other mechanisms to try to build this confidence. And part of this was confidence in the temperature stability of the G6PD test. So they're not so confident that the test can be used in the community because it can't be stored at the manufacturer's recommendation. However, in a lot of countries, that this is already happening. So among policymakers in Cambodia, we need to build this confidence. Now moving on to the second element, which is collaboration. A network of actors, including health center workers, village malaria workers, patients, family members, and patients need to work together to enable community care. Providing community care is often conceptualized as task shifting, where tasks are reassigned from highly skilled health professionals to more lay workers to save resources and expand access to care. However, I like to conceptualize this more as task sharing, which is something that acknowledges the team effort that is involved in implementing these interventions. And it's not about the skill or the approach, it's about the functionality. Each actor has value to be able to implement this intervention. And so this collaboration is rooted in a relationship of reliance. They're all reliant on one another. So it's not about how skilled they are, which they are skilled, they get training, but it's also acknowledging the value of these community health workers. And then what we see is that patients also and their family members are key collaborators. So they are a main part of this multifunctional team. And we see that collaboration is important at every step of the care pathway, from testing, diagnosis, and then treatment and follow-up. Lastly, the last element is situating guidelines. That is how an intervention is being implemented and how the policies or guidelines are being translated or situated into practice, and this should be continuously informing guidelines. At the heart of situating guidelines is the central role that implementers should play themselves in determining the policy and the guidelines. As I have done throughout my thesis, domestic stakeholders should be involved in the choice and design of an intervention. Furthermore, their input should be aligned with input from global experts and the global expert knowledge. This alignment took place in my thesis through co-creation, which was used to design treatment monitoring for the new treatments that we're looking at. And lastly, the guidelines need to be living. They need to be clear and living. So by situating these guidelines, which means how the different implementers actually implement this in their specific setting, there are certain feasibility considerations that need to be considered in how that need to inform the policy. And we found that in my study of looking at monitoring of village malaria workers of patients, we saw that they implemented adaptive strategies to be able to implement the intervention successfully in their eyes according to the added value and intended purpose. So this is important to then feed back. All the different adaptive strategies they use is important to feed back to the policy. To conclude and summarize, to be able to implement community care relying on confidence building, collaboration, and clear and situated guidelines, there needs to be an integration of village malaria workers into the health system. There should also be joint trainings, including actors across the health system, strengthening relationships and collaboration among care workers, village malaria workers, while also building confidence in each other and transferring knowledge. They both have equal amount of knowledge to transfer to each other. And lastly, an infrastructure or standard operating procedure for updates of policy and guidelines would facilitate making these guidelines updated. So to end with, though my research identifies certain things that are required to be able to successfully implement Plasmodium vivax interventions, there are some future areas that we can use to develop more research. And these include testing and building confidence in the temperature stability of the G6PD test, or in the development of a mobile health app to help support the diagnosis and treatment. That will build confidence, and even though the VMWs could also already build confidence, it'll reduce their fears a little bit. And then a effectiveness or cost analysis could help also inform how much of this we need. And then finding other ways to strengthen collaboration and the relationships it depends on. Lastly, I'd like to end by thanking all those who've made this research possible: my supervisors, my advisors, the study team, the Cambodian National Program, partners, translators, and study participants, and of course all my family and friends who are here and online who have supported me throughout this PhD journey. Thank you. Back to you, Pro-Rector.
Thank you very much, dear candidate, for a very interesting presentation. We will now start the opposition, and the first opponent is also the chair of the assessment committee, that's Professor Krutsen, Professor of Behavior Change and Technology Institute in the University of Maastricht. Professor Krutsen.
Thank you very much, dear candidate. My compliments on your work. You gave us a lot of homework to read, but I read it with pleasure. And as a chair, I can say that we were unanimously positive, so you're standing here for the right reasons, so well done. I think it's truly relevant from a global health perspective, and I think that's also reflected in the composition of your supervision team, so also my compliments to them. I think you obtained very rich data through observations and interviews with patients, healthcare workers, well, everything you just told. I think very impressive how much insight you got in this issue in the context of Cambodia. And I think these insights are crucial before jumping to solutions. I think in general we tend to jump towards solution, but I think sometimes with good intentions, but we don't understand the situation yet. And I think this really paints a clear picture on the situation in Cambodia. And based on that, you propose solutions, which you also actually just discussed already, briefly touched upon, and I want to talk more about those actually. In reverse order, the last one is about the policy guidelines and so on, and I actually think that is the easiest one from a behavior change point of view, I have to say. That's my expertise, as the chair just told. So that's also the lens to which I look at it. And then with this behavior change background, I was thinking, okay, then the next one you have is this relationship between all these healthcare workers and so on. You already touched a bit on it, but how do you want to establish that strong collaboration between them?
Yeah. Highly esteemed opponent, thank you for your question. And I think what we learned through the study was also that a lot of these relationships already exist, and they're actually quite strong. So there's a strong foundation to build upon, and that's why what a suggestion was these joint trainings, because I think it allows, well, two things. First, joint trainings in terms of the technical. So how to do the tests or refreshers on the test and strengthening that relationship. But then can also be trainings in terms of collaboration, looking specifically at how, it's about collaboration, how do we work better together? Because a lot of the time they find ways to work together that are not in the policy and the guidelines. And so we need to be able to build off of those as well. So I really think those two types of trainings And there's obviously things that happen outside of the professional context where these relationships are built as well. Like there was one quotation from one of the health professionals that was like, so supportive of BMWs because, and they were like, and even when we go to the village, they make food for us. And so there's all this like bonding and relationship building that happens in those contexts as well. So we have all those different elements, and that can also be supported as well a lot of the time.
So if I understand you correctly, they already know each other, quote unquote?
But a lot of them do. So they have like monthly meetings where all the village malaria workers in one area, catchment area, come together and they report what they've done. So and they give all their forms. That's also how they're compensated.
Yeah, so sorry, go ahead.
So they interact a lot with the health center staff. And then sometimes there are larger meetings in the province that don't happen as often where other village malaria workers, and they tend to know each other quite well since they're meeting in these forums.
Yeah, okay, so it's basically just taking it one level up.
Yes.
The strength of the collaboration.
Yeah.
And to what extent is there also, because do they have like, how to say this, different incentive structures, you know what I mean? That there's different reasons why people do things, and they differ maybe between village malaria workers, healthcare workers, patients. They have different skin in the game, so to say.
Yeah.
Did that game...
Yeah, and that comes through a lot. I mean, I think the level of dedication of government health providers varies quite a bit, but with the community health workers, they're primarily volunteers. They get compensated a little bit for the transport that they do, and then for each follow-up visit, they get a certain amount. And it's tricky because they're all kind of in different provinces. They're kind of governed by different partners. So along with the National Malaria Program, there's like all these implementing partners that work together. And the village malaria workers are actually kind of not controlled, but they're like supported by these different. So there are different schemes. Sometimes different VMWs get paid different amounts. Some don't get paid for long periods of time. So they really do it because of the commitment that they have to their community and the relationships that they have. Because a lot of the time they don't get compensated for the work that they're doing. So they believe that they're the hands and feet of the Ministry of Health on the ground.
To what extent do you think that might also be a hurdle for this collaboration? Because I think it's good that these volunteers are there and they're committed and so on, but I can imagine that it also creates power imbalances or whatever between those.
Yeah, but I think that's where the relationship of reliance comes in, because there might be that power imbalance in terms of the traditional sense, but actually when you look at all the different actors, they all hold a lot of power. So like the health center workers are really reliant on village malaria workers to be able to implement these interventions, because without them, they're kind of removed. And the village malaria worker is really the bridge between the patient and so it does create a weird, potentially power imbalance, but there's other things that weigh down.
Yeah, so it's like a positive interdependency.
Yes.
Okay.
Yeah, and I think that's why this collaboration is necessary. And actually, like, ultimately, the patient also holds a lot of power because they're the ones we're trying to reach, and so they are the ones we kind of have to work around as well to be able to help to make sure they're getting the treatment that they need.
All right, and looking at the time, I think maybe for a quick follow-up question about the other one, that was about confidence building. And I think in your presentation, you already said a lot about confidence building, but that was more about let's say, the device and whether it works as it should work and so on. But I think what I read in your thesis was also this confidence in the healthcare system as a whole.
Yeah.
And that's, of course, I think
that's
the
challenging.
example if it was easier in the sense than the healthcare system. But can you tell a bit about what the issue was there and how you step onto that?
Yeah, so that's the hardest one to really rectify, which is why I think I proposed the mobile health application, because the fear is because of the hemolytic risk, so the risk to red blood cells, because with these treatments, there's this fear. And so it's not so much about the implementers themselves, but it's that if there's an adverse event that happens, would the health system isn't quite equipped to be able to refer the patient in a timely manner, which we've actually seen it happen, and it is possible, but policymakers don't feel like on a to have the test in the community and have village malaria workers be performing the test adds an additional level of risk in their eyes. So, but that's why I think with the added reassurance of having the mobile health application, which can not just help the village malaria workers, it's going to be useful for the health kind of everyone, because as malaria decreases, there's going to be fewer cases, they're going to be testing less. So they're still going to need refreshers, and that's a good way to do it as well. So yeah, thank you.
Thank you very much. I have to, in view of the time, have to give the word back to the prorector. Thank you so much.
Thank you very much, Professor Krutsen, for your opposition. The following opponent is also a member of your assessment committee. That's Professor Robinson from the Burnett Institute in Melbourne, Australia. And he's online. Thank you for coming all the way from Australia, albeit online. The floor is yours.
Thank you so much. And thank you very much, Sarah, for a great presentation and a really comprehensive thesis that really brought together, for me, an original contribution towards understanding the complexities of implementing effective vivax. Not only in Cambodia, I think, but insights that are going to be very valuable to guiding this in other sort of pre-elimination settings, and in particular, the implementation of these approaches. Some of the things I'm really interested in hearing more about from you kind of extend on that conversation you've just been having, really, where, your insights are quite detailed about kind of the different levels of acceptability within the health system, at the community level, the health centre level, but then at the policy level, there's an entirely different set of considerations around what's acceptable and what's driving that decision-making around acceptability. So I'm keen to hear from you whether or not, based on the work you did, the insights you gained, what would you propose to be an effective strategy for establishing a co-design process and feedback loop between policymakers and implementers at the coalface of delivering testing and treatment that enables the iteration, the confidence building, the acceptability to really accelerate implementation of these? So I think in a research setting, many of the methods you employed are really suitable for that, but how would you draw upon that to guide implementation of even future novel interventions?
Highly esteemed opponent, thank you for your question. And yeah, I think it's something that anytime you go from research to routine, there's always changes that you have to make, especially because of financial resources, right? Malaria programs are already so financially strapped that they have a hard time, they have to prioritize all the time. But I think there's already kind of a foundation that you can build upon to be able to kind of implement this kind of feedback loop. So when you first implement an intervention, at the beginning, they tend to budget for several supervision visits early on, because they know that as the intervention is being rolled out, they need more supervision. But again, they kind of have to decide which sites historically or health centers have had more difficulties historically to kind of decide which health centers they're going to go supervise. But I think that there's an opportunity there at that during those supervisory visits, especially at the beginning. I think that's when you get the most information, because that's when they're first implementing the intervention. So I think there's a lot that can be cataloged at those supervision visits that they're going to implement. And then on top of that, after they do that, I think there are points at which I think there needs to be a more formal setting in terms of gathering this information. So I think at the monthly meetings I was talking about, where village malaria workers come together, the health center staff can get some feedback from village malaria workers about how the intervention is going. And then maybe say at 6 months, you can do a more formal co-create exercise where you actually do an FGD. Because there are for example, I know in the Lao National Malaria Program, there's someone who knows how to do FGDs and has done them before. And so there is some capacity within. And I think partners also help and support. So I think there's a lot of room, even within the tight constraints of national programs to be able to create this feedback loop.
Thank you so much. That's excellent. And yeah, I do think there's a lot more work to do in that space to really establish kind of clear guidelines for a process that can be highly supportive of building this confidence across all levels during implementation. So I think that's excellent. I think I've got time for one more just quick follow on. You referred to, in particular, you feeling like there needs to be a need to build more confidence in the temperature stability of the G6PD tests. And I'd just like to know whether you gained insights as to whether that is actually evidence, that the kits are stable, it's more sort of like quantitative evidence, or is this really what, you were just talking about in terms of learning by doing? They want to actually see that sort of pilot implementation can proceed in a safe way by implementing it and generate that temperature stability confidence in that way.
I think there has to be a bit of both. I think, especially in Cambodia, policymakers are really like hesitant. Even like I don't think they would want to implement, like they've seen, like there were feasibility studies that were done by Moru in Cambodia looking at village malaria workers conducting the test. I mean, it wasn't a huge number of them, but they tested it out, and in those conditions the testing supplies were not stored in refrigeration. So there's actually in-country evidence that it actually doesn't affect it too much. But I think it's also how it's communicated to them. And I think that having other countries implementing it as well without testing will build. But I think they really like having in-country evidence. And Cambodia is very good at changing their policy when they do have evidence for Cambodia. So I think even like a really small study that doesn't require too many resources, we could do it in country, test it at different temperatures, just to show that it doesn't really affect it. Could be one way, but I also think that outcomes, as you said, have a really big impact. So like with the G6PD test, when they were seeing that the treatment, it was really helping people and the treatment was getting to people and people weren't coming back to the health center all the time, they saw the impact of it. So they're like, it really motivated them and built that confidence in the test. So I think it's a bit of both, but I think you have to start with the showing evidence from other countries. And I think even if they don't equip all VMWs or some VMWs with the test, it's still going to be needed because they're going to send out either health center staff or mobile malaria workers into the forest to do these tests to get towards elimination. And even having an ice box or cool box to take the test supplies doesn't really make sense, especially when the evidence shows that it's not really necessary. So I think there's definitely ways we can do that, and different partners have a role also in building that confidence.
Thanks so much, Sarah. Back to you, Chair.
Thank you very much for your position, Professor Robinson. Now we come to the third opponent, that's Dr. Pascoe. He's from the Menzies in the Institute Menzies in the Charles Darwin University, and it is in Darwin, Australia. And thank you also for coming all the way from Australia, the University of Maastricht. It's always glad to have guests from abroad. The floor is yours.
Thank you so much, esteemed Chair, and welcome. Hello to all of the panel. I'd like to start by thanking the candidate for such interesting and detailed theses. It's really grounded in translational research and so good and energizing to read an interdisciplinary piece of work. So my question for you today is going to focus on that aspect of the PhD. So as a medical anthropologist working with STS, I'm really interested in the ways that you've undertaken and handled mixed methods research. In your thesis, you've made a point around how the post-positivist and interpretivist lenses work together and complemented one another to develop a bit more of a complete view of the interventions that you were focused on. But I would really like to hear some of your reflections or takeaways from implementing mixed methods research, and if there were any tensions or frictions, if there were certain knowledge assumptions that were being foregrounded or marginalized as you were doing this in practice.
Yeah. Highly esteemed opponent, thank you for your question. I think, so when I started out this PhD journey, when it was still in the proposal stage, it was purely going to be qualitative. And having come from working in the programmatic side of things, I really understood the value of qualitative because I had done qualitative work in that space before. But I also knew that to really get a more complete picture and to really triangulate the data, we really needed to include some quantitative data. Now that this didn't come without its challenges, because getting access to the quantitative data was quite challenging. So in theory, all the data is stored in the Malaria information system, and getting access to that proved more complicated just because of the way the Ministry of Health and the way the National Malaria Program is set up. And so we kind of had to pivot a little bit. Originally, I wanted to do a national level analysis since that data existed, but I couldn't do that. So I had to choose select sites, and I tried to choose based on burden and different characteristics. So I chose 9 health center catchment areas to collect the quantitative data. So I was almost doing work that had already been done, but it also allowed me to get more insight into the data, which I kind of liked, because if you just see it on a computer screen and it's just like it's all like, it's less personal. And I think collecting the data myself with the support of my amazing team in Cambodia really allowed me to understand the data better. And then when going through the cleaning process, which you might not, I got to do that myself, and I got to control that. Whereas in the MIS system, in the Malaria Information Surveillance System, I didn't get to do that. So there might actually be differences in the way people like record these things. So that was kind of a really good advantage for that. Now, in terms of the tensions between the two, I think the Village Malaria Worker follow-up paper really is a great one to show how important both were. Because on the superficial level, if you just look at the numbers, you just see that it was quite well adopted. But there was so much more. They were like, oh, we have 90, this very high percentage of village malaria workers doing this follow-up. But by doing the qualitative, we really saw that was not just like a small fragment of the full story. And I think that having these adaptive strategies that came out of it, and sometimes we had the high adoption, but then we were like, the way they're talking about it doesn't necessarily make it seem like they were able to do it as smoothly as what was expected or what was assumed. And I think that it's really important for the program to see, because they just see high numbers and they're like, everything is fine. But there's ways to improve it without that we get from the qualitative data. I could go on more about it, but if you had another question, feel free.
Thank you. Yeah, that's really interesting to hear. It does sound like both kind of data sets and analysis processes complemented your research. Another point that I found really interesting in your approach was all of the different kind of concepts that you were adding to STS, and how you were kind of drawing on this kind of task shifting and task sharing with the relational infrastructure approach. Would you just be able to maybe, and you've touched on this already with the other feedback, but could you maybe just talk a little bit to how you see these kind of conceptual contributions leading to more like better implementation? Like how does that actually how does the conceptual work that you've done translate in practice?
Yeah, I think that's really important. And I think it actually adds quite a lot of value. And I think that because even for like village malaria workers, there's this idea, some of this literature that talks about burden shifting, and that it's not that you're taking, you know, the burden that's on the health center and to VMWs who have a hard, like they're volunteers and they get paid very little. So I think it's definitely very applicable because with task shifting, you're really just thinking about moving it and you're not really thinking about like what it means, like the integration. And I think having that conversation about what it actually means to integrate and value these village malaria workers, because they're so valued by everyone in the health system, yet they're taken advantage of quite a bit, I would say. Not intentionally, but it happens because of the way the system is set up. And that's why I think that piece is so important. And so the idea of task sharing, where it's really a team effort and it's a multifunctional team, like I mentioned in my presentation, it's really not based on skill. It's based on what your added value to, and it's not necessarily your knowledge. It could be your relationships. It could be different. They all add different value to that team. So I think that's a really practical implication that's important. And I think the literature has kind of discussed this and moved. So it's slowly moving that way, but I think like WHO guidelines and things almost use task shifting and task sharing synonymously. And they kind of try to blur that line, but I think it's really important to kind of separate that out so we can really make informed decisions for these community health workers that are really the backbone of implementing these interventions. And played a huge role in decreasing the malaria burden in Cambodia and throughout the region in Southeast Asia, and in a lot of other infectious diseases too in Cambodia, in a lot of countries.
Amazing, thank you. I do think that your methodological and conceptual contributions really should be highlighted in this work. Of course, you've got a lot of translational and empirical work that's gone into this. But it's really incredible to see a PhD at this level making these kind of deeper theoretical and conceptual contributions.
Thank you very much, Dr. Pascoe, for your opposition. Now we come to the following opponent, who's also a member of the assessment committee. That's Dr. Meijer Soubisen, and her expertise is that she's working in the transdisciplinary global Health Institute in the Athena Institute from the Free University in Amsterdam. And thank you for coming all the way from Amsterdam.
Yeah, not that far. Thank you very much. Wonderful thesis, really also congratulations from my side. I really enjoyed reading your work and to get a deeper insight into the Cambodia context and also medical landscape there. My first question would be also on community healthcare workers, if you could expand a bit more on their crucial role. As you know, in global health literature and also in the medical anthropology literature, their competing responsibilities are described quite well in-depthly. So they act upon, they have the global health agendas, they are shaped by these global health agendas, by national policies, but also, of course, by the local socio-political context, as you described very well. And they need to mediate also between donor priorities and communities' needs. So that's what I also mean by competing responsibilities, shifting between these voices of the community while also being pressured at times by global health agendas and also ideas how they should act. So maybe you can elaborate a bit more on their role in now really implementing this radical cure approach that comes also with certain risks, as you described, quite detailed and well. So how is their role really central in this to the complex politics of delivering radical cure at the community level? So the question really goes into the direction of implementing the care. Maybe you can really zoom a bit more into the community health workers' activities and also role. I would be very curious. Yeah.
Highly esteemed opponent, thank you for your question. Yeah, I think in all my field research, I always loved talking to the village malaria workers because they were always so motivated, so happy to be there. When we were doing the group discussions and interviews, they were so engaged. And it really showed their commitment to their communities. And I think they're really, in a lot of ways, a prized possession in the landscape that is the malaria landscape in Cambodia, because there's so many competing. It's not just the National Malaria Program. There's different partners, research partners, but also implementation partners that also utilize them. So as you said, there's so many competing priorities. But it's not just that. Because they're not paid and they're not integrated into the health system, they also have jobs on the side. So they're farmers themselves. Some of them are malaria patients too. Some of them test themselves because they're like, it's their job, because they're part of the high-risk group in terms of malaria. So they're really, really an integral part. And as I said before, when Cambodia has decreased hugely in terms of the burden of malaria, and that the village malaria workers have played a central role because test and treat, right? So we had RDTs for a long time, we just had microscopy. And so like the numbers in terms of falciparum and vivax, falciparum was a lot higher, but we couldn't really diagnose vivax as well until we got the rapid diagnostic tests in 2012 in Cambodia. And then all of a sudden the vivax numbers shot right up because they were there all along, but they just weren't being detected. And so when getting these RDTs and the treatment for them in the community to people, really, really significantly decreased the burden. And then they also implemented mobile malaria workers, they go out into the forest, or they're at like entrances of the forest, and they do counseling, and they ask if they want to be tested, or they give them prophylaxis. And so they have so many jobs. And that's part of why I think health centers have such confidence in them, because they're really going through all the different, and sometimes they have to balance them, but a lot of them will put the patient first. And so even if it means spending extra time, on their way to work, to their farm, or coming back from the grocery store, they're going to stop and check in, even if it's in an informal way. So I think their motivation is quite strong. I will say there probably is some bias in terms of the people I interviewed. And because obviously those are the people who want to participate, right? And I'm sure there are village malaria workers who aren't as engaged, perhaps, that we didn't really get to talk to because it was hard to get access to them. But I would say overall, from what I hear from them also, because they also talked about the different and health center workers, the vast majority of them were very, very positive in terms of that motivation. That's why I think that integration is so important. And in Ethiopia, for example, they have the health extension workers, which also comes with its own issues, but at least they're integrated into the health system, and they're considered health workers. They're not like part-time. I mean, some of them have other means of business too, but they're really conceptualized as that, and that has policy implications. So I think they're very, very important, and they have many different tasks and do many different projects, whether it's, DBS for ST2 Besta, or like different things like that. And they manage it, they juggle it. Yeah.
Do I have time for a follow-up question? Or? Yeah, great. That was really interesting. Also, you explained quite well their crucial role, and yet I'm still curious about how can you really scale it up and make it a bit more sustainable in the end to include them. As you rightly say, they're crucial, they're even at high risk, and played even an important role in the decrease of malaria cases, which is quite remarkable to also show that with evidence. And yet they're not yet integrated. There's lots of policy barriers, I assume, hierarchies between health professionals and them. How do you see overcoming these obstacles on a system level, if you think about scaling up, which is also one of your aims to show with the thesis, that this could be potentially sustainable?
Yeah, so I think Cambodia already and a lot of countries in the region are trying to see how to make them more sustainable. And sustainability really is challenging because of the funding, right? A lot of it is dependent on the Global Fund or PMI or the President's Malaria Initiative. So it's really difficult. So even with this sustainable version, which they're trying to integrate village malaria workers into the village health support groups and basically get training on other infectious diseases and non-communicable diseases as well, to be able to fully integrate into the health system. But even to get funding for them is quite challenging. And I think that's where partners obviously come in really important, and also investment by governments and ministries of health in the village malaria workers. Now, I think if they talk to the health center workers, I think they would get feedback on village malaria workers and kind of decide how potentially this could be integrated better. This is potentially a co-creation opportunity as well, to get high level stakeholders talking to the village malaria workers as well, to kind of bridge that gap. So it's really, I think it will be challenging, but there are ways I think that can, since they're already trying to create this, sustainability is something that they're looking into, not just in Cambodia, but in other countries as well.
Yeah. Thank you very much.
Thank you, Dr. Meijer-Soebiesen, for your opposition. Then we come to the following opponent, Dr. Rosannas Urgel. She's head of the Malariology Institute at the Institute of Tropical Medicine in Antwerp, and that's in Belgium. And thank you for coming all the way from Belgium.
You want to start?
Yeah. Okay. Now
you can hear me?
Yeah.
Okay. I was starting wanting to start congratulating Sarah both for the very clear presentation and the thesis work. So I will start maybe with a broader question, and then if there is a bit of time, I have a follow-up, more concrete question. So your thesis has done tremendous work to understand the complexity of integrating G6PD testing into Plasmodium vivax case management. So based on what you have learned, can you talk a little bit on how do you see the role of G6PD testing expanding into other interventions beyond case management? And in this case, and if there is one, what or which would be the role of the village malaria workers?
Highly esteemed opponent, thank you for your question. I think that's an interesting one to think about, because G6PD testing, there are different kind of options or pathways that national programs look at. The one we're looking at is, testing every time you get a malaria case. Even if you've been tested before, you tend to be tested again, because there's some evidence that shows that there's changes in G6PD levels. So when you're prescribing, you want to be prescribing according to what they're at that time, to the levels that they're at that time. So, but there are countries that test at birth, right? They do G6PD testing at birth, and then that's in their health records, and then they use that status in their medical healthcare seeking pathway in the future. Another option that Cambodia is considering is what they're calling fingerprinting. So they're considering just doing mass testing of G6PD of patients or high-risk populations, and then using that status every time they come in for testing and diagnosis and treatment. And so they are kind of weighing the two options, and they've had pilots of both options, and both come with pros and cons. But I think either way, village malaria workers are going to be involved. One way, obviously, much more than the other. But I think even in the fingerprinting process, village malaria workers and other community health workers are going to be key to coordinating it, because they're so important to being in that bridge and being the gateway to patients. So I think they're still part of that team. Kind of like in outbreak response teams in a lot of countries, they have one person from each level because they're needed. Like the village malaria worker is really needed to reach the community and make them participate in in whatever the intervention or the project is. So there's always going to be a role for them, even if they do this fingerprinting option, which has, as I said, has its cons, and they're weighing their options. But that would mean that, in their eyes, more highly skilled healthcare workers would go out and screen people with the support of village malaria workers.
Okay, interesting. And I'm also thinking about a potential intervention to, or maybe moving away of only screening and also adding treatment, a role on screening asymptomatic infections and treatment. How do you see, maybe to talk a bit about acceptability? Asymptomatic, yes, no symptoms.
Yeah, so that's the next step, right? The reservoir, the hypnozoite reservoir, and trying to get rid of that so that it doesn't come back. And I think there's challenges with that, but Cambodia has tried to kind of counter this, and they do provide. At first, they started with ASMQ, then they moved over to Pyramax because of the side effects as a prevention. So they at forest entry points, they would provide basically the treatment to clear the blood stage to patients to take before they go to the forest. There was some pushback initially, especially because of the side effects that came with ASMQ, but that's why they changed it to Pyramax, which has less side effects, and they've had more success. Now the next question, that obviously doesn't get rid of the hypnozoites and the dormant liver stage, and that's going to be trickier because providing Primaquine to people who are not sick comes because there is a baseline risk when you provide Primaquine, and so I think that's something programs would have to weigh. It's being talked about in some programs using tafenoquine in these mass screenings, and G6PD testing would be done, and they would be provided tafenoquine, especially in countries that are approaching very close to approaching elimination. So that is a tool in the toolbox that they are looking at, and I think kind of what was brought up earlier, this implementing and kind of having safety precautions, but seeing how it happens, like how it goes. And I think there are countries in the region that are going to start testing this, and so there's going to be data to support whether to continue implementing it or not.
Okay.
Yeah.
Thanks a lot. Do I have time for a second question?
Certainly, till the aura est.
Yes. Okay. So, Sarah, now I'm moving to your chapter 7 on the routine treatment monitor or follow-up in the community, which I found it very interesting that you argue that guidelines for patients follow-up should integrate the flexibility to make them doable for the village malaria workers and patients. But in practice, there is often at least a trade-off between what is best for clinical perspective, what is doable at the community level and by village malaria workers, and what would be simply the easiest to do, right? So how should policymakers strike this balance when designing guidelines, and how can we avoid a drift from what is doable to what is easier to do?
Yeah, I think that's a really important question but I think there's mechanisms to try to prevent that from happening. I think part of that is looking at certain guidelines that are just fixed, that those are the ones that really need to be implemented, and then ones where there's some flexibility. And I think if you make it very clear which ones really have to be implemented and know the feasibility considerations, do prior about formative research to see what those considerations might be for the fixed ones, then the fixed ones are the ones that they have to implement, and then the flexibility comes with these kind of other adaptive strategies, as long as they're achieving the intended purpose and the added value, because it's not always about just the intended purpose. There's a lot of added value that comes from implemented interventions. But yes, it's definitely tricky and will be difficult to control completely. But I think part of that is also in the supervision visits that happen in national programs, and also these monthly meetings, as I was talking about before, in terms of getting that feedback from them. And I think, yeah, easier tends to take the lead most of the time, but I think their commitment to really helping people makes a difference, because in the guidelines, for example, it only said that they had to go 3 times, right, to see the patients. A lot of them went every day, or like twice a day, or like whenever they felt like on checking their fellow community. So even if it wasn't in the guidelines, they went above the guidelines. So yeah, I think that's why there is room to have this flexibility in there.
Okay, thanks a lot. Back to the chair.
Thank you very much for your opposition. Then we come back to Professor Crutzen.
Yes, I'll improvise here because I'm not sure whether you remember where we ended, but we ended with this confidence thing in our discussion. And you give a very clear answer among the situation in Cambodia and malaria. But do you think there's also something more generic to it? So what I try to say, for example, here in the Netherlands, you talked about this mHealth application. We did research on when the COVID hit us, and there was all kind of technology to support that. And actually the main driver for adoption, like from a lot of factors, was actually trust in government and government institutes. That kind of overrules everything. And we see the same also with vaccinations, not only COVID, but just in a broader sense. That is kind of a broader issue of trust in governments or institutes or things like that. To what extent do you think that also might play a role in this context?
Yes, I think it does play a crucial role, not from different levels. So with patients, there's kind of almost an inherent trust in health workers. Cambodia has come a long way in terms.
You may finish if you want. You may also say enough is enough.
I can finish really quickly. So there is an inherent trust that over time they really favor traditional medicine, and that's still there, but a lot of trust has been built in health workers. So if the health worker tells them this is a better treatment, they trust that. And the same token, for healthcare providers, there's a lot of trust in the Ministry of Health to have vetted what interventions they're implementing, and so they say, oh, if the national program said it's good to implement, that already brings a level of confidence, and then the rest builds even more.
Thanks so much.
Thank you again, Professor Crutzen. Mrs. Cassidy-Seyoum, the time appointed for the defense of your thesis has passed, and the degree committee will now discuss the quality of your thesis and the way you defended it. And therefore, I ask you and your company to leave this room and follow the Padela's pose. And after the deliberation, the beadle will come and collect you to return this room.
Please, parallels, please. Please follow. Please follow the parallels.
Well, elaborate enough.
Yeah, I know. Oh,
Zijn er nog 2,5 minuten?
yeah.
Please remain standing.
I reopen this ceremony. Mrs. Cassidy-Seyoum, the degree committee here present has assessed the quality of your thesis and the way you defended it. And in view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of Doctor. And Dr. Engel is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Please rise.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
By the authority vested in us by law, and in conformity with the decision of the committee here present, I hereby confer upon you, Sarah Ann Cassidy-Seyoum, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with a degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university.
Please be seated.
Dear Sarah, I don't know if you can hear me or see me.
Okay.
Great. Dear Dr. Cassidy-Seyoum, congratulations. Wonderful moment and a fantastic achievement. It's really been a privilege to be with you through this PhD journey. You have really met all the challenges along the way with a lot of determination, grit, and stamina. And it's beautiful to reach this moment now. In the foreword of your thesis, you talked about it takes a village to complete a PhD. And you'd certainly had quite a village around you. Not 1 or 2, but 7 supervisors, each bringing their own expertise and style. And with that came very different kinds of advice. One pushing for more numbers and less text, the other one for more details and more explanation, and yet another one for a deeper theoretical grounding. Many students might have felt pulled in too many different directions by this, but you managed to navigate it all with remarkable diplomacy. And of course, it wasn't just the content of the feedback, but perhaps also the cultural flavor of it. With 57% of your supervisors having German, Dutch backgrounds, the feedback could sometimes be rather direct. The Australian side had perhaps little chance to really shine through in that mix. But hopefully the overall environment in Darwin, where you spend most of your time, when not in the field, made up for it. This village of supervisors deserves a thanks. It's really been a privilege for me as well to learn and along this way. Special thanks to Nora. Her insight and guidance have been really invaluable. And for me, this journey, your journey, has been very much also a learning opportunity and learning together as a supervisory village. Sarah, what impressed me most throughout this PhD was your sheer dedication and hard work. In German, we would call this you've been an Arbeitstier. I looked it up in Dutch. It's a Werkpaard. Apologies for the accent. In English, perhaps simply someone tireless and unstoppable. You were remarkably organized and disciplined. I will never forget the Excel sheet you made to keep track of your interviews. Every single step was planned. When it would be coded, when it would be reread, when it would be double-checked, all neatly organized in half-hour intervals. I'm quite glad you didn't schedule when you had to blink or breathe. That level of detail is extraordinary, Sarah, and it shows the stamina and determination that carried you through such a complex PhD project. What also stood out was your honesty about the intellectual side of the work. After we pushed you to think a bit more about what your data really meant, you came back exclaiming, "This is really hard work." And you were right. But as with everything else, you rolled up your sleeves and got on with it, and the end result speaks for itself. Preparing for today, I asked the other supervisors to share one or two things they especially appreciated about you. And I'd like to mention just a few of those reflections here. Michelle, who couldn't be here with us today because she's based in the US and it's in the middle of the night for her, she remarked how nice it was to see you building on your earlier work with the Malaria Elimination Initiative and the University of San Francisco. For her, the PhD felt less like starting something new and more like the next logical chapter, almost if you had always secretly prepared for it. And then there were our colleagues in Cambodia, particularly Bipin and Rupam, who confessed that they were worried you might struggle with the lifestyle and especially the food during your fieldwork. Of course, they didn't realize that you had grown up in Laos. So in reality, you were probably the best prepared of all of them. Needless to say, those worries didn't last very long. Nora, who you met in Rotterdam and Maastricht, she cherished the moments of cycling through Rotterdam with you, searching for your friend who was meant to take you to a tennis match, of course, while the two of you carried all your belongings with you. Sarah, you seem to have friends and family everywhere where you go, not only in Rotterdam, but also in Darwin. You knew everyone in the student accommodation within the first couple of days. And I'm sure it's thanks to all of them that you found some headspace during these very busy PhD years. And finally, Rick reminded us that the defense should be a celebration of all the amazing work you've done. I hope that today felt like a celebration of your perseverance, of your achievements in this really important milestone. So here's to you, Sarah. Congratulations again. You really are now the mayor of your research village. Thank you.
Thank you, Professor Threemer, for this very nice laudation. Dear Dr. Cassidy-Seyoum, also on behalf of the University of Maastricht, I would like to congratulate you with this with the degree you have acquired, and I hope you can celebrate it, and I wish you all the best for your future. Of course, congratulations also for your paranymphs who have supported you so well. And of course your supervisors, Dr. Engel, Professor Threemer, Dr. Ley, Professor Rice, and Professor Lawrence. And of course your family, friends and colleagues. I hope they can all celebrate this day. I would like to thank the members of the opposition for all their work online and on site. And of course the Padel and the Beadle in good English, and the technical support team who made this hybrid session possible. Having said that, I'm about to close this academic ceremony. What we're going to do, we're going to make a picture with the people online on the background. So the supervisors and the opposition online stay online. I'm going to make a photo here and then a photo at the foot of the stairs. And I ask you, the family, to wait outside, and then after the photo making at the foot of the stairs, we are going to congratulate you, and then you follow us. All right? Having said that, I close this.